Hi, everyone. Welcome to episode 52 of Simulation Pulse Live. I'm Jon Brouchoud, the founder and CEO of Arch Virtual, developers of Acadicus, and we have Bill Ballo here from Madison College.
Howdy.
And today we're going to talk about scene editing. And one of the things that you can do with Acadicus is basically roll up your sleeves and delete things and download content packs and bring different patients in. And we really tried to model those scene editing tools on how simulation labs currently work, where you get to go in and move the mannequins around and rearrange things and set things up however you see fit. We wanted to have that flexibility from the beginning. That's what we heard loud and clear from our customers. And that's why we built these tools. So we want to talk a little bit about those today. And I guess I'll turn it over to Bill. I know you've done a lot of scene editing. I reached out to Dr. Sleeman as well. He just created a really cool scene in his lab to help with his fellowship or resident training that's coming up. So maybe we'll hear from him in time to be able to show that scene, hopefully. But
Excellent.
Bill's done a lot of scene editing, and he and I have worked together on a few things, and he's done a bunch of things on his own. So I'll let you kind of talk about your experience and editing scenes and the value
Yeah.
of that.
Yeah, I think it's actually one of the things that really sets Acadicus apart from some of the other products that are out there, is that, instead of having to if I want to move a an IV pole from sitting at the left of the patient to the right of the patient, or vice versa, right? Because I know in a scene that that would make more sense, or maybe that's the way the the simulation lab is already set up, and so it helps with student familiarity when they're learning a new way of doing simulation. So if I want to do that, all I want to do is grab the IV pole, go like that, and put it over there. And that's what I want to be able to do. And with some of the other products you weren't able to do that. You'd have to go, hey, could we get the IV pole to be put over here? Okay, so the cost on that is going to be, let me tell you. And I thought, well, that doesn't make a lot of sense to me. Like I want to be able to move things. The other thing is that since the scenarios weren't pre-baked, right? So you don't have everything all baked in. I get the question a lot, like, oh, what scenarios are there in there? Well, let's stop for a second. I will absolutely tell you that there are all kinds of stuff that are in there, all kinds of things that have been built, all kinds of things I have built, all kinds of things other people have built, all kinds of things, OpenRN has built, right? So we'll definitely talk about that. But I don't want to start from there with faculty, and I usually don't. I don't start from a point of, hey, we have this scenario, you should use this scenario. Okay? I don't start from that point. I start from the point of, what do you want to do? And that's something that I can do with the Catechist that I can't necessarily do with other products, is that I just go, what do you want to do? And they go, well, I have this scenario that I've been using with my students for the past 5 years, and I really, really like it. And I've done a lot of work to refine it and to make it what I want it to be and all of that. And is it possible for us to use that? And 9 times out of 10, it's, oh yeah, absolutely. Because usually the scenario doesn't include, like, I want a helicopter to land on their house, and then, it doesn't include something like that. It's usually something, actually, I guess you could do that in the catechist, couldn't you, Jon?
You
John's sitting there
could.
like, wait, we could do
We
that.
have a
I'm like,
Black Hawk, yeah.
we could, that's right, yeah. So a perfect example of this was our nursing faculty. So they have a scenario that they've been using for a long time, and they use it in their regular simulation, their mannequin simulation, and sort of as a way to get some faculty buy-in. They were like, we should use this scenario. This person's familiar with it and they're excited about VR. This person's familiar with it and they're excited about VR. And so let's use that scenario. I said, okay, great. What's the scenario? And they say, okay, so it's a congestive heart failure patient, and he then goes into, he's kind of treated for congestive heart failure. He comes to it's not an ER scene, it's a floor scene, but he came to the ER the night before or the day before, and now he's up at on the cardiac floor, and they're pretty sure he's going to need a cath. It wasn't spotted as an emergency cath in the ER, right? So you can kind of see where this is going. Like, wow, this is pretty interesting. Okay. So instead of the typical, hey, presents at the ER, needs an emergency cath, this was presented at the ER, had chest pain, evaluated. They decided to admit him, and now he's sitting there and his chest pain seems to be getting a little worse. And you're like, oh, okay, all right, so what's going to happen? Oh, he's going to go into cardiac arrest. And you go, okay, he's going to go into cardiac arrest. All right. And I'm sitting there, my wheels are spinning, and I'm going, yeah, I like this. Okay, I like this. We can do this. Okay. So what I did was I took two scenes essentially. I took our dynamic cardiology scene, and then I took a scene that was actually set up for cirrhosis and GI bleed. And I based it off of the cirrhosis and GI bleed. I took the patient that was in there, one of our Gen 2 patients. I took the room that was there, and I went in and I went, you know what? Okay, he's not going to need like all of this, like, he's not going to need the ultrasound and all of that. So let me get rid of the ultrasound. So I'll take the ultrasound out. That's gone. I like the ultrasound. It's really cool, but they don't need it for this case. Okay, ultrasound's gone. Okay, what else do we need? I need a monitor that will reflect cardiac arrest, but will also reflect everything prior to that. Plus, then they're going to have to be able to shock him and all of those kind of things. And I'm like, okay, so I need an EMS style monitor, something that's a little bit more suited to EMS that we would be more likely to see in the ER. So I grabbed the one from dynamic cardiology, took that, placed that in the room. Now, what I have is I have the two scenes that are melded together. And then I went, well, what other things do you want? I talked to the faculty, had them come in and try it out. And they were like, okay, well, where's the 12 lead ECG? And I went, 12 lead. Yes, you're right. Okay. So I got the 12 lead, put the 12 lead stuff in there. And that way they could do a repeat 12 lead on this patient, because essentially he's a congestive heart failure patient. He's going to go into cardiac arrest, but he's complaining of chest pain. So they're going to repeat a 12 lead on him. So you can kind of see now where this entire scenario that they were already using, I took two scenes, sort of melded them together to make it work well. And honestly, it's been great. We've run it, I don't know, probably going on maybe 20 times all total. When we count, like, they usually go in either in twos or threes. So we've probably run it all 20 or so times total. And what was nice was the faculty were like, yeah, this is almost exactly like this scenario that we already use. Yeah, there were some differences. We focus a lot on what they're doing for skills, but in this one, we're focused more on interpersonal. We're focused more on communication with the team and communication with the patient. So, John, I've spoken enough here. I'm going to pull it up, and you go ahead and speak on.
Yeah. That's so I think of what you just described, I always call it the innovation loop. And when we first started building in the simulation space, we paid really close attention to what happens in simulation labs. We interviewed simulation directors and managers and lab managers all over the country and just asked, what's important to them, if we're introducing a virtual dimension to this existing modality, like what are the important ingredients to keep in mind? And that flexibility was key to be able to design and run their own simulations. They didn't want canned scenarios. They didn't want pre-baked things. They wanted to be able to roll up their sleeves and build things. And that's, I think, what I fell in love with the first time I went to IMSH was just how crafty and how scrappy people are in the simulation community in terms of like how they're mixing and matching things and what if we did this and what if we did that. And that's how simulation evolved as a craft, because of the fact that it was the instructors and the physicians and the nurses and people who are actually in the field were in real time determining what that curriculum is, what scenario do you want to run, what's important, or even like things that come up in the immediate things. In some cases we've seen hospitals that have a patient that has a rare or unusual condition coming in, and they want to prepare their team to make sure that they're ready for that patient. Well, if you hire a programming team and say, I need a VR simulation and I need a pediatric patient with these conditions and this environment, it'll be 18 months, it'll cost $500,000, it'll be just a whole different thing. But with the scene editing tools, we've seen they can go in and say, I need this patient, this environment, I need this equipment, and it's all set. They save it, they run the scenario, and now they've got it. That's the innovation loop. It's the people who are actually teaching, the physicians who are actually practicing, that are designing and determining those scenarios, and not like a team of programmers that are like, what should we build? And maybe they work with one SME to create that. But now what you've done is essentially hard coded a scenario around the way one SME did it. And I
Mhm.
know that because that's how we started. We built programs like that initially back in 2017, 2018 in IMSH, where these were scenarios that could only do one thing one way. They were all baked in. It was just very much on the rails. And there's some value in that. I'm not saying that that's not a valuable way to approach VR, but again, everybody who took the headset off was like, yeah, that was great, but like, I want a different patient. I want to be in an ICU. I don't want to be in an operating room. I want to be in a pediatric, area, or I want to be in a rural clinic, or I want to be in an exam room, whatever the case is. You don't want to have to wait or try to solicit a VR team to like build that content for you, come up with a budget to build that content. Now we do build a lot of custom content that's like really kind of beyond the scope of what we already have in our library, but we're building tools that are essentially the content is essentially building blocks. So once we've got content, you can mix and match it with the other pieces of Acadicus, just like Lego blocks. And so it's really keeping the instructors, keeping the physician in that innovation loop, because that's where the good stuff is, right? Like, and I think that's the biggest challenge we have building this software and taking the more difficult path of building those scene editing tools. That it would have been so much easier to just build pre-programmed stuff. It would have cost a whole lot less and we could be charging a lot less for the software, but we just listened and we knew that that was important. And now that we have that, we have to educate people about what you can do, because they don't get it until they see it. And then once they see it, you can get that moment where they're like, oh, this is just like what I'm already doing. I don't have to learn a new thing. I don't have to reinvent the wheel. I can do what I'm already doing, but in a virtual world where we can have a whole bunch of different environments and patient types, and you've got a whole lot of different pieces of content that you can work with to achieve your goals.
Yeah, and I deal with so many people that are very tepid, right? About like, oh, VR, I don't, and that's the look too. They're like,
Yep.
I don't know. And I go, well, hold on, let's put the headset on. If you don't like it, we'll stop. There's never it never happens that way, right?
Every single time.
Where they go, I don't want to do this anymore. They go in, they go,
Yep.
oh, okay,
100% of the time.
okay,
Yep.
yeah. And I go here, like just take this here, listen to his lung sounds. Go ahead. And they grab the stethoscope and they put it on and they listen to his lung sounds and I go, okay, now hold on. Now, right now I have it set to wheezes. All right, but ready here, I'm going to set it to crackles. And I go to crackles and they're like, oh yeah, that's good. And then, okay, well, yeah, but that was fine crackles. Here's coarse crackles. And they're like, oh, yeah, that's right. And okay, and here's absent breath sounds, or here's diminished, or and they go, oh, okay, wait, so you can do this on the fly? Like you can just change it? Yeah, you can change it, you know? Um, and so I'm going to go ahead and share my screen right now.
And you
So
can
let
do
me,
that with, we have a diverse range of, age, race, gender, ethnicity. We're trying to be as expansive as possible. It's one of the things that simulation I think could do a better job of. And I know there's a lot of attention being placed on that, but, really creating simulations that authentically represent the patients you're actually going to be serving in the real world when you graduate or in the field. And so you've got, a lot of different types of patients. It's not like we just have one mannequin and that
Right.
one mannequin does these things. You can have all different kinds of patients involved in this scenario.
Right, exactly. Exactly. So this is the scene I created. So what I'll do is after showing this scene, I'll show the two scenes where pieces came from. So there was a monitor that was up here on the wall that wasn't the monitor that I wanted. It didn't give me the capability that I wanted. And so because I wanted, when I go into my sim manager, right, and I pull up my monitor, I wanted all of these waveforms. I wanted sinus, rhythm, asystole, all of that kind of stuff. And I wanted to be able to just change it. There it is. Boom, he went into asystole, right? Or I wanted sinus Brady, and I wanted to be able to put him into sinus Brady. Or, and here I'll pull up a little closer too, right? Theirs actually calls for him to go into VFib, and then eventually he goes into asystole. And then he comes back out of asystole and into PEA. So he goes back into like a sinus rhythm with no pulse, right? And then, again, these are all things that I can change as I'm going through. Okay. So I can change all of this as I'm just going through. And I wanted this specific monitor. And this came from dynamic cardiology. And all I did was go in and find the dynamic cardiology pack. Oh, there's the monitor I want. Grab it, pull it out. I want it there. And so I put it on this table that was already there. And then when we got the code card finished, I put the code card in here as well. Because originally I just had a table over here with some of the medications on it that they would need, but then the code cart was created. And once the code cart was created, I went, oh, well, that needs to be in this scene. So I made that change again. So instead of having to go, oh no, I got to do this whole big thing, I got to completely change everything. No, I just went in, I grabbed the code cart, stuck the code card in there, went, oh, that's not exactly straight. There we go. Now it's straight. Perfect. And I left it in there. And now the code card is in for the cardiac arrest patient. There's the 12 lead, right? They asked for 12 lead, and I went, oh yeah, sure, we can put 12 lead in there. And so they can run a 12 lead on him. Now there are some things in the scene that are actually invisible. So I have labs for him that show elevated troponin, and I have an ECG that come up right here, and then a chest X-ray as well. But the students don't get to see that until they ask for it. So they have to ask for it first. They have to say, or run the 12 lead ECG first. So they got to go and put all of the stickers on. They got to, like, you can't just go, I want a 12 lead. No, you have to put all the stickers on. That's how real life works. And it takes time. Real life takes time. With the students, they're like, oh man, this is crazy. We got to put all these stickers on. Yeah, you got to put all the stickers on. Yeah, you do. I mean, that's not the way this works in real life. You can't just go, I'd like the 12 lead. Where's the 12 lead, please? So when I do this, when I actually do this in VR, I stay in VR. I act as Carl. I act as the patient. That's his name, Carl. I act as that patient, and I stay in VR. And then when they ask, when they run that 12 lead, then I finally make the 12 lead visible. And I just click on it and go visible, and that's it. It's 2 buttons to make it visible. Same thing with chest X-ray, all of that kind of stuff. If they don't ask for it, they don't get it. They don't get it. It's just the way it is. And then there's medications for him. These are also in the cart, but we found that it was easier to just kind of leave them laying out like that. But you can stick them back in the cart. I like them out there like that. You can stick them back in the cart. We also needed a BVM and all of that placed in here, so I just grabbed the BVM, the squeezable BVM. So I'll show you now the scenes that this came from. And let me pull up the simulation.
While you have that open, can you, go to the shared library. So that that shared library is available to everybody that's subscribed to Acadicus. So if you've got a lab, you get access to all this. Now, again, just like Bill said earlier, everybody wants to know, well, what scenarios do you have? Well, these are the scenarios, right? You can go through here and you can use these. But the more important thing to keep in mind, and the reason why you're investing in a virtual simulation platform like this, is you can take these and you can modify them to be whatever you want. So any one of these, if you go into EKG lead placement, it's like, that's not how I teach it. I want to teach it a different way. You teach it however you want. You can change it. You can go to a different environment. You can take any of the OpenRN scenarios. They're built with Legos. So you can just take it apart and you can build it a different way. And that's what more of that needs to start happening, because that sort of like cross, like that collaboration, I think, is where the magic is. And like we've seen so many times where, one school takes a simulation, makes a modification, shares it, and then another school takes it and they make a modification and then they share it. And it's just this kind of collaborative, evolving thing that I feel like that's taking simulation to a whole different place. It's almost like a whole different category. We see a lot of that collaboration, obviously, in existing simulation, but it's really hard because you're sort of in your own location. There's geographic limitations, but in this virtual world, somebody, we've seen, like with UW School of Medicine, a physician in Vietnam and a physician in Madison can stand in the same room as if they're together, face to face, even though they're thousands and thousands of miles apart. So that ability to share these scenes and edit together and share and collaborate is a whole nother level of different, kind of a game changer in the simulation area.
The reason I opened up the routine active labor one is because this is just another good example that I have. So when we had students in here working on the routine active labor, so they're working with this patient, she gives birth, all that kind of stuff. And they kept turning around to look at the clock back here. And then they turn back to her. And then they turn back and look at the clock. And then they turn back to her, right? And I'm not trying to make anybody dizzy. But they were like, that clock is absolutely in the wrong place. I'm like, really? Explain to me why. They said, because the clock should be above her head. That way I never have to break with my conversation with the patient. And I went, wow, yeah, you're right. So I just went into VR and I was like, hold on, grabbed the clock, pulled it over, stuck it on this wall over here. Now I've left it in the shared library. In mine, the clock is over here. That I just took it out, pulled it into my sim labs and modified it. And I just went, yeah, you're absolutely right. You know what? You're right. And I grabbed it and I put it right on over there. The other thing they said to me was, you have stuff in here that I don't understand. They're like, you've got like blankets here, but I can't open them up and put them on the patient. And I'm like, yeah, you know what? That's a good point. I said, those aren't actually blankets. Those are for something different. And they're like, well, they look like blankets. I'm like, you know what? You're right. And there's a blanket that I can turn on and off on this mannequin anyway. So I just said, all right, we'll just delete those from the scene for now. Delete, done. And they were like, thanks, like that was perfect, because they were getting they were so focused on grabbing these blankets and trying to put them on the patient that it just got annoying for them. And I'm like, okay, yeah, that makes sense. They're for something else, but okay, sure. And then they came over, they went, why is the cutter way over here? Why is the umbilical cord cutter way over here? And I went, oh, that's a good point. Like, the umbilical cord cutter's kind of far away, isn't it? They're like, it should be over here. Oh, wait, there's already one over here. And I said, you know what? You're right. We have two. My mistake. Click, delete, done. Right? So now there's less confusion, right? Everything that they're focused on is focusing in the middle. And I didn't have to call anybody. I didn't have to call John. I didn't have to call Rick and say, hey, guys, can you help me out? We got to get this out of here. I didn't have to call anybody. I didn't have to say, hey, I want the clock moved from here to here. And they're like, okay, $2,000. No, I just grabbed the clock off the wall. I went into edit, clicked on the clock. I actually made it hand grabbable because I work better with the hand grabbable than I do with the gizmo. And so I made it hand grabbable. I walked over to it. I grabbed it off the wall. And then I walked over, I teleported over and stuck it on the wall right behind the patient so that it's right there. And that's it. That's simple scene editing that you would do in your normal simulations that, that you have to do. You have to be able to do that in your normal simulations. The other thing I found, and this is an interesting one too, John, I know I've mentioned this before, but I have found that when students go to pick up the stethoscope, they get very, very focused on the ear portion of the stethoscope, right? So they grab it and they pick it up, and then they've got this stethoscope and they've got the other end, the bell end, and they're trying to put it on the patient, and they're like, this doesn't. So actually, what I do in all of my scenes, I delete
I do too.
the ear portion.
Yep. Yep.
I delete it. And I go, this is the stethoscope bell, and you can just pick up the stethoscope bell.
Yep. Yep, that's a good call.
Because that
And
just
some of
works
those
best for
things
me.
are somewhat, they're hand wavy, but I think if we're honest, I've sat in on a number of simulations, and a simulation can be kind of hand wavy. And I think what we're trying to do as much as we possibly can is, as we bring this into the virtual world, have less and less things that are hand wavy. Like, for example, the having the patient's family member standing there, or having the patient moving around and looking and blinking, and it's not static, it's not inanimate, it actually can move. So there's a little bit of less of the hand wavy, but there's still some. And it's sort of a trade-off that you're making. And even like with the blankets, it's not enough necessarily. It'd be great if we had big cloth blankets you could fold out, then we'd have to charge a lot more for a catechus. We try to keep things, the cost down, but like in a scenario, it might be good enough to be able to grab that and say, I would put a blanket on the patient right now, and then have that blanket appear, because you can control that in the simulation manager. Again, it's a little hand wavy, but it's at least the prop is there so that the student has to indicate that they know what needs to be done, and they can check that box. But yeah, the idea is to get less and less of that as we go. We're just getting higher and
Of
higher
course.
fidelity with input from our customers.
Yeah, absolutely. So this is the GI bleed, the cirrhosis and GI bleed scenario, the well, setup. I hesitate to call them scenarios. And the reason I hesitate to call them scenarios is because when you get in that mindset of scenario, you start to think that's all you can do. Like, if I call this the GI bleed scenario, you're going to go, okay, that's set up for GI bleed. We don't teach GI bleed. Never mind, no thanks. No, 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 no. That's not what it is. And I certainly don't want to call it that. So this is what was created for a GI bleed scenario. Now, I didn't show the hallway in my other scenario, the one that I did that's Carl Shapiro. I didn't show that scenario, that hallway, but in the hallway there's no cart. What we found out was the first iteration, the first students that went through it, they spent so much time over at that cart going, okay, I got to do my hands. I got to get my gloves on. Okay, well, why do my hands look the same? It doesn't look like I have gloves on. And I'd had to go, okay, you have gloves on, you're fine. And then they go, okay, I got to put my hair thing on, and I got to put the, and you're like, whoa, hold on. This is not an isolation room. And they were like, oh, then why is this here? And I'm like, all right, sounds good. You're right. That wouldn't be there, right? You'd walk into a regular room and you'd grab some gloves off the wall. It wouldn't be, okay, delete, just let's get it out of there. And the faculty were actually really grateful for that. So you can see there's a relatively similar setup here. Oh, the 12 lead was, or is in this one. In the other one, it wasn't. But then you can see all of the stuff that is still here for the GI bleed scenario. So, you've got the ultrasound, and you've got, the bed information, raising, lowering, all of that kind of stuff, which you can do from your sim manager. So you don't have to worry about that. But then you can see the IV pole is a little different. We had a little different IV pole in the other one. That big monitor that's up on the wall, I took that down because that monitor was not the one that I wanted for that particular scene. In this particular scene, there's actually two blood pressure cuffs. Now, this blood pressure cuff is better suited for like a long-term care facility, and this is a little bit better suited for a hospital room. So I deleted this one and kept this one, right? So you like the standalone stuff, right? There's your standalone end-tidal CO2. I just deleted that. I didn't really need that. So I got rid of some of that redundancy that was in there. So there's the room that scenario was based on. And then if I go into dynamic cardiology, it's the monitor that I wanted. And I knew that I wanted that particular monitor. So I just went into the pack. I was like, oh, there it is. Okay, grab the monitor. Again, I leave it. I immediately make it hand grabbable, and then I just grab it with my hand and put it where I want it. Because I'm not real great at using the gizmo personally. But so there it is. There's the monitor that I wanted. And there's some of the equipment that I wanted, the pads and the BVM and that kind of stuff. So those are some of the things that I wanted. And I decided I'm going to pull that in to that scenario. And it was all about the faculty coming to me and saying, this is the scenario we want to use. And instead of saying, sorry, we don't have that, would you prefer using the congestive heart failure patient that doesn't go into cardiac arrest? No, I said, yeah, I can make that. That's fine. I have respiratory therapy will be coming in a couple of weeks. They're supposed to come in this week, but I got sick, and so I couldn't go in. But they're going to be coming in now. I think it's next week now. And what they want is they want a patient who is in congestive heart failure. But they wanted labs that were consistent with a patient who needs to be intubated. And so I said, okay, well, what are those labs? They said, well, do you have these labs in there? I was like, I don't need it. Tell me what your labs are. And they're like, okay, give me your lab report. Like, if you have a lab report that you would like to be seen in there, just give that to me. I'll make an image of it. I'll stick it in there. And it's your lab report. It can be branded, it can be Madison College's lab report. I don't care. Just give it to me and I'll put that in there. And that'll have all of the information that you want. And they're like, oh, that's kind of cool. Like, yeah. And then what else? And they're like, well, then we want the students to intubate. And I was like, okay. So here's what we're going to do for that one. We're going to do 2 different mannequins. We're going to use a generation 2 mannequin for everything up to that. And then we're going to go to one of our intubation mannequins for sort of everything after that. I'm like, is that okay? Because those 2 I wanted to separate out. I wanted to have some separation between those 2. And they're like, well, can they intubate the Gen 2 mannequin? I'm like, no. And it certainly doesn't look the same. Anyway, you want the mannequin that's specifically set up for intubation. Well, that's something that I'm like, hey, in the future, maybe we have to have a Gen 2 patient that does have that capability. You can lay that bed back, you can lay them down, you can set them up for intubation. And that's innovation that comes out of now the SimLab. It came from them, not from me, not from Jon, not from Rick saying, not from the other people who are awesome. But we didn't even think of that. I didn't think of it. I'm like, oh God, that's really good. Yeah. So there's our next, like, hey, that's the next thing we want to do. So yeah.
That's awesome. And I remember when we toured some of these simulation labs, one of the things that it really blew my mind was that they would always have a sheet that was like the orders that the instructors would fill out for the simulations that they had coming up. And I still have one of the sheets, like I'll just keep it confidential, but like I refer to it all the time, and it showed, what kind of environment are we simulating? What is the patient going to look like? The labs, all the things that you just said. And then the sim techs or the sim ghosts, they'll work behind the scenes and prepare it and get input on like, hey, is this kind of what you had in mind? No, let's move this over here. And then, okay, it's simulation time. They've got everything set up. And it's sort of like this, so it sort of evolved into what we call the simulation plan template. So we've got this Google Doc that we use as a standard way of guiding creation of the scenarios. So if somebody comes in and they want to work with Acadicus Assist, our team can come in and do those edits real quickly based on those simulation plans. But yeah, I mean, it's really something that can happen in real time. And we've often had it where, we'll do this over a Zoom call where a customer will say, look, I don't have a team member that can learn the scene editing tools. I want to work with your team on Acadicus Assist to make those edits for us. So what we'll do is go into their environment, share our screen, and then they just say, yeah, move that over here, move that over here. And we're just doing it in real time. It takes like 15 minutes, depending on what we're doing. And we can build out a whole scene, save it, and then we're done. So that capability is definitely it's reflexive. It can happen quickly and in real time rather than being sort of a static thing that doesn't change. And that matters because healthcare changes over time. You know, it's not a
Yeah.
static thing. There's nothing static about healthcare or medicine in any way, shape, or form. It's constantly changing. So by the time you bake something into a hard-coded sort of step-by-step sequence, you know, there's research just came out that says it's got to be done a different way. Well, now you're back to the drawing board, and like that's never going to change. Like that's never going to stop. Like that's always going to keep changing. So I think you need a platform that's as flexible as the industry, flexible and as dynamic and changeable as the industry itself.
I agree. I agree. And I'm bringing up now the mass casualty, John, because this is one that you and I just worked on together. You mentioned Acadicus Assist. This was sort of, John and Bill having a little fun, but making sure that we had a good mass casualty that was set up. And I remember how we did this. So John was like, I'll move the patients, you set the information cards on them, right? So you just started grabbing patients and putting them around and going, okay, let's put this patient here. And I was like, okay. And I kind of came in and I just started setting conditions for this particular patient. Now, the nice thing about it is John and I took maybe 2 hours all total, John, I think, from scratch, like we blanked out a scene and then we went in and just started bringing stuff in. Um, but you don't have to do it from scratch. You can go into this scene and go, you know what? I don't think so. I would rather this patient be this, this, or this. I would rather this patient be this, this, or this. And you can go and change those patient conditions on your own. And you
That's
can say,
exactly what
you know
Jamie
what?
did. You know, Jamie from
Right.
Western, you know, she went in here and she's like, yeah, you know, I want to hide some of the patients and make them really hard to find, right? So she
Yep.
went in, took the scene editing tools in a very short amount of time. She was able to create her own iteration of it. For all intents and purposes, you go in here, it looks almost identical, but she made a few key modifications that were specific to what she wanted to teach with her goals. So it was a very different kind of approach.
Yeah, and I think she even asked about this patient in particular. She said, you have a patient by a purple tent. Why did you set it the way you set it? Right. So this is the patient has a heart rate of 28. You reposition the airway, it's unchanged. You check your radial pulse is 123. You check your cap refill, it's 1 second. Major bleeding, there's none. Mental status follows simple commands. So you might initially go kind of, yeah, that's probably mine. Wait a minute, why is that not minor? Hold on. Actually, the main reason it wasn't minor is that it had to do with pulse and respiratory rate. Patients are yellow. It had to do with pulse and respiratory rate. The sustained pulse and respiratory rate, higher pulse and respiratory rate like that, that actually would change this patient to a category yellow. Because we're assuming that there's something going on potentially internal. We look at this patient and we go, hey, nothing. I don't see any bleeding. I don't see any, there's not even any major wounds on this patient. How is this patient in category yellow? The patient's in category yellow because of a sustained heart rate, sustained respiratory rate that are outside of that sort of, normal area. So, and that's just and the thing is if you go, no, he's wrong. I don't like that. No, that patient should be minor. That's okay. Change it to what you think is going to be right for your student. Or you're looking at your triage and you're like, no, I'd rather it be. That's it's all up to you. It's all up to you. You can go in and change this. You can say, nope, I disagree that this patient is. That's fine. I put this patient in this way specifically to kind of, be one of those, wait, is it green? Is it yellow? What's going on here? Right. So, and then you can just change it. You can go around, you can just change it.
I think even though there's somewhere in here is that same patient, the Gen 2 patient that was in the
Yeah,
scenario
I
you
believe so.
were already in. You know, they're all, you know, they're just these are the characters and cast of Acadicus that you can reuse in whichever way you want. I mean, just the fact that you're in an MCI scene is also part of the flexibility, right? Like if we had really zoomed in on one scenario or one batch of scenarios, it would have taken us a long time and a lot of investment to build those scenarios. And then you've got scenarios that are all sort of exam room based. They're only for nurses. It's only one kind of industry, one kind of use case. And that's fine. You know, there's a lot of platforms that are going that way. But when you build building blocks, you can just build building blocks that are all kinds of different things. So, we're not stuck with just one environment. Here we are in a downtown scene, right? But we're using the same patients that you're training nurses with and training paramedics with and training, you can do, I've seen, that scene with the green floor that you were in, it's like I get deja vu of all the different scenarios I've seen happen in that environment. I've seen
Mhm.
post-intubation desaturation. I've seen heart rhythm disturbances. I've seen anatomy lectures. I've seen,
Yep.
that floor, if that was an actual, I always tell people if Acadicus was an actual physical simulation lab, it would be the largest simulation facility in the world, right?
Oh
There's
yeah.
millions of square feet of
Yeah.
scenarios that are just all different environments, and every iteration is slightly different. It would be bigger than a city, literally,
Yeah.
it's just this massive environment with all these different possibilities, and they're Lego blocks you can mix and match. It's like Roblox for simulation.
Yeah. Yeah. By far. And so this is another example of what John and I did to edit the scene. So originally this garbage can was sitting over here, but and there's or this garbage bag, sorry, but there's a reason that that garbage bag is there. I wanted my students to identify this as a potential secondary device. So one of the things that we looked at when we were building off of this was the Boston bombing and the fact that during the Boston bombing, there were two explosions, right? There was sort of that initial one, and then there was the one that was down by the starting, or either way, one or the other. I don't remember exactly which one went first. But there are at times secondary devices that could be set up, and we are trained that there are secondary devices that could be set up that are actually intended to harm police, fire, and EMS. So you get on scene after an explosion, and that person who has done this is not that far away, and they know that police, fire, and EMS have come, and now they want to hurt police, fire, and EMS because the more of us you can hurt, the more patients you can, or the more people you can ultimately hurt as well. And so I still wanted this to be in the scene, but over here just didn't work. So we just went, all right, well, John, I think you picked it up and went, I'll just put it over here. Is that okay? And I was like, yeah, that looks good. Right. And we can put it anywhere. Like if you say, you know what, no way they would put it there. They'd put it way back over here. Oh, look, there's a tertiary device. Uh-oh. Right. Or nah, they wouldn't do that. They put it way back over here behind this building or something like that. Then you can do that. Pick it up, put it behind the building, and you're set. Wherever you think it's going to be best. Jamie wanted it spread out a little bit more. That's great. That's perfect. That's exactly why we have the ability to edit these scenes.
And
And I
the
think she
same,
wanted less cars, right? Or
yeah,
more
or
cars.
in one more car. Yeah, I think she
One more
had
car.
it
So she
added a
just pulled a
car.
new
Yeah.
car in. Yeah.
Yeah, in one of this same combination of assets was also used by another school for, I believe they called it the curbside community, and they had a pop-up clinic. So they were teaching social workers on how to work with people in a curbside kind of a community, and they had a pop-up clinic set up in one of these buildings, and just a completely different use case, like just a completely just not like right angle to what we're teaching here, but yet using exactly the same content, right? But just a totally different scenario, totally different target audience, social workers instead of paramedics. And but you mix and match, you delete a few things, add a few things, change a few things around, and now suddenly you've got an entirely different scenario.
And we can go even further too, John, because right up here on the rooftop up here is where our HVAC simulator is set up.
Yeah.
So for HVAC class, so like, and I'll actually bring us into that. So this is going like non-medical, like completely left turn here. So up here on top, I'll bring up the HVAC simulation. But yeah, that's where our HVAC is at.
And the funny thing about that is that that environment originally was for the American Society of Safety Professionals. They had built that environment originally for training people on how to properly wear harnesses, and we still have all that content in there, so you can teach, proper fitting for harnesses and, inspecting the different harnesses. There's different ones that have, cuts and tears, and you have to check the sizing and and everything. So we did it up on that rooftop, and there's no ledge, so it's a safety hazard from the get-go. You know, there's a lot of different hazards they have to keep an eye on. But then it turned out to be great for, because there's these refrigeration units. So, you know, the HVAC instructors came in and said, "Yeah, this is perfect. Just, you know, we'll work here and teach students how to use a manifold gauge." You know,
Yep.
so I don't think we ever in a million years would have imagined that when we were building that for ASSP.
Yep. And there it is. And this is the ledge you were talking about. And every
Yep,
time I
same
go into
scene.
this scene and I stand on that ledge, I'm like, oh boy.
It's a peaceful
Um,
day.
yeah.
It's better
Yeah,
this
no,
way.
no bombing, no
No,
bombing.
nothing.
Everything's
Yeah,
good.
no disasters. Yep.
Everything's good. We're just doing some HVAC work up here today. Um, and and the other thing was oh geez, I forgot. I train ran off the tracks there. But yeah, so there's our HVAC. So now we have our simulator for that.
That's awesome. This was my son's favorite spot for playing hide and seek when we were developing and getting
Oh yeah,
feedback.
yeah.
We did a lot of hide and seek.
And we've upgraded this too, because originally it was just the manifold gauge. And then the instructor came in and said, well, what about recovery, refrigerant recovery? So we have to do something with that. And so refrigerant recovery came into it. And that sort of joined in with that. Um, so yeah.
Yeah, I mean, keeping in mind, you know, that it's Acadicus itself is industry agnostic. Like it doesn't know the difference between a manifold gauge and a heart. You know, it just doesn't, you know, it's building blocks just the same, but you know, we are focused in the healthcare and medical space largely, but many of the schools we're working with are encouraging and sort of challenging us to explore other areas because there's a lot of, you know, if you look at the core use case that we're trying to solve, anything that's, you know, difficult or expensive or complicated or you know, otherwise impossible to teach in a physical environment. That's what we're doing is we're simulating a patient so that you can learn how to communicate and do these different skills in a safe and controlled environment without the risk of harming anyone. Well, the same is true with the HVAC. We heard that from the instructors that built that, where they were like, you know, it's dangerous to work with this in many cases in our shop because if they release that refrigerant, we have to shut the whole thing down and there's a whole risk and there's a danger there. So if we can do that in the virtual world, we can let them practice in a safe and controlled environment where there's no risk of harming anyone. Exactly the same use case. So just different content, but a completely different, but using the same environments.
Yeah. Yeah, absolutely. Yeah. We just, like, trying to think of other, like, our vet tech, right? We took the anatomy room that I was using to teach. And I think actually I think that was the skeleton for the OR too, if I remember
Yep,
correctly.
it was. Yep.
So yeah, it was the skeleton for the OR, basically just cleared everything out, turned it into an anatomy room, and then turned it into a vet anatomy room. And it's just been like it's kind of mix and match. And then even some of the newer stuff we have, like the muscles of facial expression for dental, um, that too was the new commons. So the new setup for the commons became the area where we have muscles for facial expression. And actually my thought in this was to move muscles for facial expression into the dental clinic because I think it makes a little bit more sense. It kind of connects the two now. And just, have it in the dental clinic. Stick that asset in there, real easy to find and grab, and then put it in and you're all set. And that don't forget to save the scene.
You got to save the
Forget
scene.
to save the
Yes,
scene.
yes,
Don't
yes.
forget. Don't do all that work and then not hit
And not save
save.
it. Yeah, yeah, yeah.
So,
It's funny that operating room you mentioned. We also use that as the a derivative for the delivery room for the neonatal simulation. Like
yeah.
it's just been used
Yep.
for all different, and I think that was originally NSU did all their intubation scenarios in there, and it's just yeah, it's so funny. It's like I joke about like the floors would be filthy if this was a physical space because there's thousands and thousands of people going through.
Oh yeah. Oh yeah.
It's nice to be able to just hit load and it's all fresh, brand new, just reset real quickly.
Yep.
So Well, that's scene editing tools. I think we did a great job of covering, all the different capabilities. I know we've gone over some of this before, but if anybody's watching this and has any questions or wants to, see a demonstration of what this actually looks like, we didn't actually show what it's like to actually edit a scene. Maybe at some point in the future, there's plenty of videos on our website and our tutorial section that show kind of how to use the tools, and pretty straightforward. There is a little bit of a learning curve. You are learning how to edit and model and modify in a three-dimensional environment. There's going to be a learning curve associated with that, just like learning any new game or platform. But once you get the hang of it, it's pretty straightforward, and the possibilities are limitless. So
Yeah,
appreciate you tuning in today. Go ahead, Bill. Yep.
one other thing to mention, and I remember because my train had run off the tracks there while we were standing up on top of that building, and I'm looking over. We did that development for HVAC. One of the things to think about, like if you're in a nursing program or something like that, and you're wanting to use Acadicus, buy Acadicus, use Acadicus, that kind of stuff, it's a whole lot easier if you have buy-in from other programs as well. Like we serve 24 programs at Madison College. Not all of them use Acadicus, but a lot of them do. Because when we can say vet tech and HVAC and architecture and nursing, like all of those programs are using it. And so if we can get that sort of combined financial interest from all of those different programs, that makes it a lot easier. If you're looking at it and you're going, oh man, our nursing program's going to have to do, start looking at other programs that would be interested in using it. Botany is a great example. If you look at other programs that would be interested in using it, that definitely helps out a lot. So that was the thought that I was having when we were standing on top of the building. So
yeah, that's a really good point. Really good point. Well, and it's the same is true with the XR lab itself, right? We see a lot of, like you say, nursing school comes and says, we want to use virtual reality for simulation. And they envision sort of like building a little pocket of their part of their school, of their department, and they're going to build out and have, computers or VR headsets or whatever they decide to go with. And then it's sort of like landlocked in that one school. But those headsets are useful to all the programs like you just mentioned. So considering the possibility of building a school-wide XR lab, I think it's inevitable. I think the world is moving in that direction. Lots of schools are doing this now. And so thinking bigger about what XR can be for your entire school or your entire organization, it's important to understand your use case and build your evangelists and get your use cases squared up. But I think thinking bigger, like Bill said, I think is going to help get budget, and it also expands access to capital that you might not have in one department, right? You can get dollars that are assigned for a larger, and there's lots of grants and lots of ways to fund these things. And once you build that XR lab, every single time that happens with every customer that's building an XR lab, we're seeing them thrive. It just explodes in popularity. And the challenge goes from trying to get people interested in it to trying to keep it in reality, because everybody's like, I want to do this, I want to do that, I want to do this, I want to do that. It just becomes like this really exciting thing that everybody wants to be doing. And now you're trying to figure out how to scale it and continue to grow access to it. But if you just think about it, like we just need a couple of headsets, or our students can do this in the corner by themselves in this one division of this one department of this one, that's just not, it's great. Start there if you want, but sooner or later, the paramedic program is going to be watching what you're doing, and they're going to say, how do we do that? And then all the other departments, so think bigger.
Yeah. Last week for me, Wednesday was biotechnology. Thursday was nursing students coming in to do their orientation. And Friday was the women's basketball team. So,
Wow.
I mean, like those were that was 3 days. That's just 3 days for me. Next week is sort of set up the same way. Where, I have, and the thing is like the women's basketball team coming in, that was kind of a break for me because we play games with them. Like we do team building games and they loved it. They had so much fun, and they're laughing and I'm laughing and we're having a good time. And like Wednesday was work, Thursday was work, Friday was play. We had a great time. We just had a lot of fun. So, and it keeps me interested in it too, because I'm like, okay, which way can I go now? What new thing can I learn now? I'm one of those people that constantly wants to learn things. And so I'm like, well, what can I learn now? What new thing can I learn now? And so that's it. It helps me. So, not only financially, but then, for whomever is in that lab, to have more than just, the one thing that they're doing. It's really great.
Awesome. That's
Yeah.
great to hear. Well, and it's exciting too that I remember even when we first started doing these episodes, there was still a little uncertainty about the staying power of VR and simulation and whether or not this was actually going to become a thing. And these early headsets were, lower resolution and they had issues and they were clunky and they made people motion sick. But all of that's been sort of like solved, for the most part. And the costs have come down on the headset. The resolution is getting greater. The interactivity is more intuitive. And now we're seeing, very large companies making substantial investments to continue improving on that hardware. And if you look at like Meta Quest, I think there's rumors that there's another version of the Quest coming up pretty soon. And, they're continuously improving it. They're continuously lowering the cost. This is here to stay. This isn't going away. And we're learning how to make it so that there's increased accessibility across multiple devices. So you can use this even if you're uncomfortable wearing a headset, that's fine too. You can go into the non-VR version and do many of these simulations. So this is here to stay. We're seeing a lot of success with it. And I think as we demonstrate and share those use cases more and more, it'll just keep building momentum. So
Agreed.
cool. Well, thanks everybody for joining us.
Great
And
conversation.
we'll see you next Friday. Thanks, Bill.
Take care.
Cheers.